Hello, my name is Dr. Don Buford. I'm an orthopedic surgeon in Dallas, Texas, and I'm honored and humbled to be invited once again to participate in the Castelvi Spine Symposium. And I look forward to sharing some of the latest information on evidence-based orthobiologics use in the spine. We're going to focus on platelet-rich plasma and bone marrow aspirate concentrate. Where you see the QR code, that is a link to the handout for this presentation. You can also easily access this presentation by going to buford.info/Castelvi. These are my disclosures. They're also available at our Academy online reference sites. So why consider orthobiologic therapy at all? Number one, surgical implant design and engineering materials are maturing. There's slower innovation. And what I mean by that is we don't need stronger metals for the most part. We don't need stronger suture for the most part. Our surgical failures are increasingly biologic in nature, meaning that things aren't fusing, tissues aren't healing back to bone, or soft tissues aren't healing together. And so as a result, I think that we can make the biggest impact on orthopedic care by harnessing human biology. We do have FDA regulatory compliant orthobiologic choices. The two that I'm going to focus on in the time constraints we have here today are platelet-rich plasma, or PRP, and bone marrow concentrate. Non-SVF adipose is also in a unique position and can be used in the United States, but we don't have the time in this presentation to discuss it. So let's talk about platelet-rich plasma. I know that Matt Murphy has given a wonderful presentation by now on the contents of PRP and some of the biologically active things that are in our blood that we try and harness with these therapies. So I'm not going to spend too much time going back over that. How have we been quantifying PRP? Primarily, we've been talking about leukocyte content to date, and we have two basic flavors: leukocyte-rich PRP, which is loosely defined as a white blood cell count greater than baseline, and leukocyte-poor PRP, or LP-PRP, which is, again, loosely defined as a white blood cell count less than baseline. Now, we all have to recognize that there are other hematopoietic cells that are important, like granulocytes and monocytes, but primarily when we talk about PRP in the literature and amongst colleagues, we're talking about LR-PRP or LP-PRP. One of the other things you'll see in the literature is PRP concentration. This is typically where PRP is reported as a range, i.e. 5x to 7x over some baseline number. This is typically reported by the manufacturer as they try and position their protocol or their device in the market. I do think that knowing the platelet counts is better, and we're going to get to that in just a little bit. Other factors that are used in the various platelet classification schemes that are available include things like platelet activation. How should we quantify PRP treatment? So this is getting into a little bit more opinion. There is something called the platelet dose. I do think that these treatments are drug therapies, and like any other drug, I think there's a dose response curve. And as a result, we need to know the platelet dose. It's a very simple formula. Platelet dose equals PRP volume times platelet count. I always get asked, how do we get to billions of platelets in our PRP therapies? And this is how it works out. If we have a typical patient that has a platelet count of 300, that's really 300,000 per microliter of blood. And that is the same thing as saying the count is 300 million per cc of blood. You have to multiply microliters by 1,000 to get cc's. And so a typical hematology analyzer, the printout would say the platelet count is 300. Well, that's the same as saying 300 million per cc of blood. Now, let's say we take that same patient and we draw blood and we make PRP using a protocol or a technique that makes 5x baseline. So now their platelet count is 1,500,000 per microliter of blood. That's the same thing as saying their count is 1.5 billion per cc of blood. So a hematology machine would print out the result as 1,500. That patient's PRP platelet count would be 1,500. And the point here is that that equates to 1.5 billion per cc of blood. So to quantify the dose, we just need to know the volume that's being injected at that count. So if we have a hematology machine telling us that the PRP has a platelet count of 1,500, and we put in 6 cc's, 6 times 1.5 is 9, and the units are billions now. So that would be a platelet dose of 9 billion platelets. Now, I think this is really important to understand clinically because all PRP is not the same. And I'm going to give you two very relevant clinical examples. These are real world examples. If you start with a platelet count of 200, that's the patient's baseline platelet count on their whole blood hematology. You can use one commercially available PRP system that is a 10 cc blood draw. From that 10 cc's of blood, you put it through a spinning or centrifuging process that creates 5 cc's of leukocyte poor PRP. If you do the platelet count on that leukocyte poor PRP, the platelet count comes back as 260, and you're going to inject 5 cc's at that platelet count. That is a dose of 1.3, again, 5 times 260, 1.3 billion platelets. You take the same patient's blood, run it through a different company's PRP protocol. Their protocol asks for a 60 cc blood draw. So right out of the gate, you know there's more platelets. They create 6 cc's of leukocyte poor PRP from the same 60 cc's of blood that they initially drew. The concentration on that is 6x, which results in a platelet count of 1,200. When you multiply that times 6 cc's that's injected, 6 times 1,200 is 7.2 billion with a B platelets. That is almost a 6-fold increase in platelets using the same patient's blood on the same day, just varying the blood draw and the platelet protocol, the centrifuging protocol. However, both of them are called PRP. They may have vastly different biological effects. In fact, one may not work, whereas the other one may work in a fantastic way. So, and I'm not even going to say that it's the high dose that would always be better than the low dose for a given clinical situation. We need, studies and clinical data to tell us that. But I think we can all agree that 7.2 billion does not equal 1.3 billion, and there's probably going to be some clinical differences in those two drugs. So now let's look at some clinical data. I'm going to start by looking at the SI joint. There was a nice study published in 2020 looking at the effectiveness of ultrasound-guided PRP injections in relieving SI joint dysfunction. This was a level 3 study, so the average level in most orthopedic literature is 3. This had an N of 50, and what these authors found was that PRP gave a 2-point pain score decrease from 1 month all the way out to 1 year, and a corresponding 10% functional score increase over the same time interval. And so this is pretty good clinical data showing that PRP can be quite effective in relieving SI joint dysfunction. In 2016, these authors published a level 1 study with an N of 40 comparing steroid versus leukocyte poor PRP for SI joint injections. What they found was that by 6 weeks, the group that was injected with leukocyte poor PRP was doing better than the steroid group. By 3 months, the leukocyte poor PRP group was still having a significant beneficial effect from the injection, whereas only 1 out of 4 of the steroid group was still doing well. So yet another study suggesting that PRP gave better pain relief and lasted longer than the steroid group. So the question I would pose to the audience is, shouldn't we wait to fuse the SI joint until after someone fails an appropriately dosed and placed PRP injection? Why should we jump to a surgery for which we can't really go backwards when we have injection therapies that may be just as effective or even more effective? Next, I want to talk about caudal epidurals. This is a level 2 study with an N of 50 published in 2011. And what these authors demonstrated was that a 20 cc caudal epidural can treat low back pain and radiculopathy all the way up to the L3 level. And so that is something that we use clinically in our office almost every day when we do our caudal epidurals. We keep our patient in a neutral position with no head tilt. So they're not in Trendelenburg, they're not in reverse Trendelenburg. And given that positioning, we feel that we can treat pathology up to L3. And that's been shown in our registry data over a decade now. In 2020, this level 1 study with an N of 50 very nicely demonstrated that leukocyte-rich PRP was better than steroid from 3 months all the way out to 6 months for a caudal epidural injection. And these are patients with complex chronic degenerative spinal pain. This study was just published this year. This is yet another level 1 study. And notice that the quality of these studies is starting to improve. I'll grant you that the N is still a little bit low, but at least now we're getting randomized and blinded studies looking at these treatment alternatives. In this study, it was a 24 cc blood draw. The PRP was characterized as being nearly 3 times baseline, and 3 cc's of that leukocyte-rich PRP was injected versus triamcinolone. What the authors determined was that the PRP group had significantly less leg pain at 6 weeks, 12 weeks, and at 6 months. The PRP group was also functionally better. They had better ODI scores at 24 weeks. So here's a relatively high-level study showing once again that leukocyte-rich PRP in an epidural location works better than a steroid injection. So the question I would pose once again is, shouldn't we be doing PRP epidural injections if they give better pain relief and last longer compared to the steroid alternative? And not to mention the fact that in other areas of orthopedics, we know that doing steroid injections, sometimes within a year of a surgery, can lead to increased rate of infection and increased complications. And so if somebody's having a steroid epidural injection, steroid facet injections, anything around the spine, and then subsequently has spine surgery within a year, what if that data matches what's shown in other orthopedic literature? So why not use something safe that doesn't have that potential complication? Let's talk about lumbar facet joints. In 2016, a nice level 2 study was done with an N of 46, comparing 5x leukocyte poor PRP versus steroid lidocaine injections. Both groups had improved VAS, ODI, and RMQ scores. But here's the big difference, and this is a recurring theme if you haven't picked up on it. The steroid group results peaked at 1 month, but the leukocyte poor PRP group continued to improve through 6 months. So once again, even though in this study, the effects were the same, but the duration of benefit was significantly longer in the biologic group. What about cervical facets? This was published last year. Level 3 study, 44 patients, 1 injection of PRP with 3-month follow-up, so not a very long follow-up duration. 70% of the patients had significant pain improvement. 80% of the patients had significant NDI score improvement. 41% of the patients had at least 50% pain relief at the 3-month mark. So just almost a pilot study just showing that this works in the cervical facet region as well. So that raises yet another question to pose to the audience. Shouldn't we consider PRP facet joint injections if they give better pain relief that lasts longer and once again, potentially safer? Why wouldn't you? And now let's talk about the lumbar disc. This 2016 study published in the Journal of PM&R with the senior author being Greg Lutz. It was a level 1 study, 47 patients. Greg compared harvest PRP versus a contrast agent control. This was a single injection of PRP. And what he concluded was that the PRP group had significantly better pain and functional scores at 2 months, and that these results were durable out to 1 year. And this was a very well done study. It's been validated by other authors across the planet, basically. And this is really good evidence that PRP is very effective in the lumbar disc. So shouldn't we consider PRP intradiscal injections if they give us pain relief that lasts a year with minimal complications? So now we're going to change gears a little bit and talk about another orthobiologic. We'll talk about bone marrow concentrate. This is something we've done in the office more often than not. Sometimes we do this in conjunction with our surgeries where it makes sense, but most of our BMC procedures are done under ultrasound guidance in the office. So I want to address the elephant in the room right out of the gate, which is this even safe? And the answer is yes, it's safe. BMC has been used in orthopedics for over 3 decades. Chris Centeno and his group looked at over 2,300 patients and found no significant increase in complications or side effects compared to steroid injections or any other injection. The question of whether or not there's an increased cancer risk by doing these bone marrow procedures has been definitively answered by multiple authors, but that was studied specifically by Philippe Hernegal in over 1,800 patients, and they found no increase in cancer risk in patients treated for orthopedic diseases with autologous BMC. Another study was done to look at the complication rate at the beginning of the learning curve. And what Christian Hendrich and others found was that BMC aspiration was safe even in the first 100 cases that a clinician does. So this can be a very reproducible and very safe clinical procedure. And then the coup d'etat is a study published by Philippe Hernegal, current president of Facet, who has 30-year follow-up on over 125 patients where he treated patients with AVN of the hip due to corticosteroid osteonecrosis, where one side had the typical decompression, the other side had an augment with bone marrow concentrate, and over 30-year follow-up, there was no increase in complications, no other significant side effects of note by using bone marrow concentrate. So I think we can definitively say that BMC is safe to use. Now it's up to all of us to prove when and where it makes sense to use it. So why would we use BMC instead of PRP? It looked like from the beginning of this talk, PRP works pretty good. Well, what I would say is that BMC is safe, it's effective, it's legal. It's a non-surgical treatment like PRP to reduce inflammation, reduce pain and dysfunction, and to promote soft tissue and cartilage health. But here's the thing. At least to date, the early data suggests that BMC may be more anti-inflammatory than PRP, and thereby being more effective for some clinical conditions. The data suggests that BMC therapies may last longer than PRP, which would be a distinct advantage, or they may be more anabolic than PRP or some other orthobiologic options. And so it's definitely a different drug, and we need to sort out clinically where it fits into our armamentarium. One of the questions I get often is, Donnie, where should I get the bone marrow from? And my answer is always, well, we have to get it from where there's the highest concentration of cells. All other things being equal, we should look for an area that's safe and that's the least painful. And when you consider all of those things, the answer is clearly the iliac crest. The primary reason is the iliac crest has the highest concentration of mesenchymal stem cells in the body. So if you were going to draw bone marrow from the proximal humerus or around the knee, you would have to draw 2.5 times more marrow to get the same number of cells as from the iliac crest. And that just practically isn't reasonable most of the time. If we're drawing 60 cc's of bone marrow to treat a particular condition, you would have to draw 240 cc's of bone marrow to match that stem cell count if you were using the humerus or the knee. I understand that it's attractive to try and get bone marrow from the same surgical field. So if you're treating a shoulder problem, maybe you get the bone marrow from the proximal humerus. But I want you to think about that and turn it on its head. Why should we take bone marrow from the very place where we're doing the surgery if that's what we're asking to heal? It makes a lot more sense, in my opinion, to take bone marrow from some other place where there's a high concentration of cells and put that into a surgical site, into an injured location where we're trying to increase the overall healing potential. So if I want bone marrow, I only aspirate the iliac crest, and that's just a basic rule. Iliac crest aspiration can be done in the office. We have videos on YouTube and online. If you'd like to see them, we've published our technique. It's been validated. It's been revalidated by another author. So I have no qualms in telling all of you that you can quite safely do the posterior iliac crest bone marrow aspiration under ultrasound guidance. You don't need a drill. You don't need a mallet. I draw 60 cc's minimum, which is also the minimum amount of blood I'll draw to make PRP. But in terms of bone marrow, it takes about 9 minutes to get that done. What are the stem cells in bone marrow? Now, we have to be careful. These are mesenchymal stem cells. They can't become anything. So things in the mesenchymal line include bone, cartilage, muscle, tendon, and ligament. Dr. Arnold Kaplan there on the left coined the term and then subsequently recoined it as medicinal signaling cells. And the reason he did that is because of the misperception that these MSCs were becoming all of these things in the column on the left. And we know clinically that they don't really act like that in vivo. We don't put in MSCs and they become cartilage. Rather, what they do is they secrete things that have paracrine effects. They are the little factories that create and produce and export these proteins and cytokines. In a very similar fashion, we shouldn't forget that there's also another type of stem cell in the same bone marrow where we're getting MSCs, and those are HSCs, hematopoietic stem cells. These are the cells that become all the things in our blood, RBCs, WBCs, and platelets. Here's the thing. MSCs and HSCs both create the same cytokines and growth factors until they reach terminal differentiation. And so through most of their stem cell life, they both make the same paracrine growth factors and cytokines. And so they basically are on the same side in the same army fighting disease. So I'd like to give you some take-home bone marrow concentrate pearls. HSCs and MSCs both secrete the same biologically active proteins, cytokines, and other things until they're essentially mature differentiated cells. Bone marrow plasma is a very different substrate than blood plasma. For example, there's much higher interleukin-1 receptor antagonist protein in bone marrow plasma compared to blood, and we'll come to that in just a minute. MSCs and HSCs are not becoming anything. It's important to talk our patients off of that Dr. Google search and to make sure they understand that the way that these cell types work is that they're paracrine. They are secreting things that create effects in other cells. I think one of the things that's been debated, but is really not controversial and incontrovertible even, is that concentrating bone marrow raises the cell count. If you have a bone marrow aspirate, you may have an 18 million total nucleated cells per cc number when you study it or when you run it through your cell counter. But in a reasonable, commercially available centrifuging process, your bone marrow concentrate will be 6 or 7 times that sometimes. So you could go from 18 million total nucleated cell count to 108 million in a 15 or 16-minute centrifuging process. So you definitely can concentrate cells by centrifuging. Now, another thing that's about to be counterintuitive, if you heard everything I just said, which is the bone marrow concentrate procedures are not just about cells. It's not just about MSCs. It's not just about HSCs. You have to remember that most of the literature only pays attention to the MSCs. And so in our same-day procedures, we're typically only injecting between 25,000 and 50,000 MSCs. That's not a large amount. But if you add in the HSCs, then you get into millions of cells. But even that is relatively small compared to the numbers that clinicians can get when they culture these cell types. Both cell types are secretory, just to emphasize that. They create paracrine effects. These are the two major proteins. These are both large proteins that are present in our bone marrow that have well-studied and well-known biologic effects. So interleukin-1 receptor antagonist protein blocks the action of IL-1. It is perhaps the most potent anti-inflammatory, a biologic anti-inflammatory that we have available to us. You can look at this publication from 2018 that's been repeated by other authors like Brian Cole in other journals. And you can see here that in bone marrow concentrate, that IL-1RA is significantly higher than in PRP. One of the other ways we can increase a protein like alpha-2 macroglobulin is to use a hemofilter. And so A2M is a well-studied large protein. It's an antiprotease. It blocks the breakdown of cartilage and other proteins because it blocks the catabolic proteins. Centrifuging in the office, in a typical office setting, does not increase A2M. It's far too light, if you would, or doesn't have a high enough density to be layered out in a centrifuging process. However, if we centrifuge and create a plasma layer, we can then run that plasma through a filter like you see at the bottom of the screen on the right, and that filter will remove water from the plasma, thereby increasing the concentration of the remaining A2M. And so that is one way clinically that we could potentially raise even beyond the baseline A2M concentration in plasma by dehydrating it with a relatively readily available filter. Sorry, these filters are between $100 and $200 typically, if not even less than that. So they're not overly expensive in the face of the overall cost of these procedures. So now finally, let's look at some clinical data for bone marrow concentrate. What about the SI joint? We saw there was level 1 data for PRP. Well, with bone marrow concentrate in 2023, not so much. The only thing we could find was a picture in the journal of SI Magic and Hope. What about caudal epidurals? Again, in the PRP literature, pretty good data that the PRP is very effective and more effective than steroid for caudal epidurals. Bone marrow concentrate, the American Journal of Not Yet. So somebody out there in the audience needs to get this done. What about lumbar facet joints? Intuitively, it makes sense. These are joints, and BMC has very potent things that seem to be beneficial for degenerative joint disease. But in terms of clinical research, the Spine Journal of Level 12 Studies is the only place we can find something. So really not available yet. What about cervical facet joints? Again, with PRP, we have some data that PRP is effective for cervical facets. Bone marrow concentrate, not so much. Techniques well described, we just don't have the clinical outcomes data yet. So where do we have data? Well, here's one area, lumbar fusions. This was published in 2014. This was a level 2, relatively small N of 25, but this was a prospective randomized study. And this author looked at level 1 to 3 level fusions, and they compared allograft plus BMC to autograft for these lumbar fusions. And what Dr. Johnson discovered was that at 1 year, the results were identical. Couldn't tell the two patient groups apart by fusion mass or any other criteria that he used to measure outcomes. And so that suggests that you can use allograft, augment it with BMC, and get the same outcome. Cervical disc. So this is not cervical facet, but cervical disc. This was published in 2017, level 2 study with 2-year follow-up. Dr. Patin looked at patients with multiple level cervical disc disease. And what he discovered was that the VAS and NDI scores were still significantly better than pre-procedure at the 2-year mark. So here's some early data. Of course, it bears repeating because we don't have a literature robust in outcomes yet. But this is early data that suggests that BMC into the cervical disc can give a long-lasting clinical effect. What about the lumbar disc? Well, Dr. Patin, along with some friends of mine, Matt Murphy, who's I think already spoken at this meeting, and some other PhD researchers, Dr. Suzuki, Dr. Ted Sand, have looked at injecting the lumbar disc with bone marrow concentrate. And then they followed that cohort over 5 years. And what they found was that with a 1 or 2 level injection into the disc, depending on the clinical indication, that patients improved, maintained their improvement all the way through 5 years. All of these patients essentially came into the study group having been told they needed some sort of disc procedure, whether partial discectomy, microdiscectomy, or what have you. And yet at the 5-year mark, after a single disc injection, only 1 out of 4 had gone on to have the surgery that had been recommended. So essentially, another way of saying the same thing is 75% of the patients that were told they needed disc surgery did not need it after a single intradiscal BMC injection. The other thing that was nice about this study, and having worked with Matt Murphy, this doesn't surprise me at all that it was well characterized and well quantified, was that they found that patients that had a CFU count of greater than 2,000 improved faster and had better results. So it's one of the few studies in the literature quantifying a stem cell count, I shouldn't say stem cell, a mesenchymal stem cell count, or CFU per milliliter count, and correlating that with a clinical outcome. So another study published last year looking at lumbar disc. This is a level 3 study, a relatively small N with 32 patients, but 92 discs were treated. These, again, were intradiscal injections, just like Dr. Patin's study. And these patients were followed for 1 year. The authors reported a 50% improvement in VAS and ODI at 1 year. So another study supporting the fact that an intradiscal lumbar injection of BMC can be beneficial. In my experience, 85% of my orthobiologic practice is with PRP. 15% is with bone marrow concentrate. The question is why? And the answer is simply because that's where the data is at this point, in my opinion. So I want us all to get engaged and stay engaged. We need to add to the clinical literature. I think the evidence-based orthobiologic use for spinal conditions is growing rapidly. Clearly it is. Data collection is critical. Procedure documentation is critical. Quantification of the orthobiologic is critical. And I believe the collaboration, not only across multiple centers in the United States, but across the planet, will accelerate acceptance and improve our clinical outcomes. Thank you very much.